The overall clinical cure rate was very high for all of them, but the imiquimod 5-FU tretinoin combination was 99% effective.
Welcome to the Learn Skin podcast with me, Dr. Raja.
And me, Dr. Hadar, where we discuss all things skin.
Join us as we delve into the art and science of skin health in today's episode.
Hey, Raja, can you say the thing I told you to tell them?
Of course. We are board-certified dermatologists. This podcast is meant for educational and informational purposes only and is not considered medical advice, nor does it serve as a substitute for professional care by a doctor or other qualified medical professional. All opinions shared do not express the views of Learn Health, Inc. Let's get to the good stuff.
Hey, Raja, how are you today?
Hey, Hadar. I've been thinking, with all this extra sunlight in summertime, God, how are we treating these skin cancers when they just get out of control? We need some help with that, don't you think?
Oh my gosh, yes. You're in California, I'm in Florida. We're getting hit with sun all the time, and so are our patients. And so they come to clinic with a lot of skin cancer, and the burden sometimes, is just beyond repair, so to speak. And, recently I came across this paper that really changed my practice, I must admit. It's one of those things that you find these little nuggets, and I started asking around. I looked at the authors, and guess what? They're right around the corner. So we invited them to join us to tell us about this mystery therapy.
Yeah, we're really excited to invite this dynamic duo. We have Dr. John Shen, and he's a board-certified dermatologist. He's in private practice. He's been there for over 15 years at Shen Dermatology in Temecula, California. It's in the San Diego area, and I had the privilege of actually visiting John as a resident. It's like a decade ago. So, I have a soft spot for John, and he's always been innovative. Can't wait to hear about what he's going to tell us. But we also have Dr. Anna Nichols, who is a fan favorite from the IDS, Hadar, as you know.
Oh, yeah, big time.
Yeah, big time. Assistant professor at the Department of Dermatology and Cutaneous Surgery at the University of Miami. That's the around the corner for you, while John's the around the corner for me. Figuratively speaking, California is big, but we're a lot closer than Florida. And so she's been working on looking at it from a research perspective to see what John's been doing. And so the two of you together, I think we're really excited to hear what you've uncovered and what your approach is that might be novel when it comes to skin cancers. Welcome to the podcast, Anna and John.
Thank you so much.
Thank you for the invitation.
So let's just jump right into it. And John, I guess I'll start with you and tell us what inspired you to think outside the box and come up with a new treatment for these patients? And who are those patients?
Sure. After finishing my training in New England, I moved out to San Diego, and I was astonished by the sheer volume of skin cancer patients I was treating in my first job. And it's not uncommon for me to perform, I would say, 2 biopsies an hour. And in a given day, I would have 15 new skin cancer patients.
Wow.
That had to manage. And every day I was just falling behind.
I mean, that's Temecula and San Diego for you right there. California, right?
Yes.
Just unrelenting sun.
Yes.
Right. And a lot of those are recurring, right?
A lot of them are on the same patients. In recurring in the sense, it's the same person coming back again and again. I would have patients that come back every 2 weeks on a different location of a new skin cancer. And it became a management issue. And at the same time, I was practicing in an area that suffered a tremendous economic dislocation. You guys recall the subprime crisis. And so I had to find an inexpensive treatment quickly to treat these patients that really didn't have the money to pay for their skin cancer problems. And so reaching back to my residency and thought about what my mentor taught me, started to play around with imiquimod and 5-fluorouracil and adding a little bit of tretinoin. And it took me a few years, but basically perfected the recipe for treating basal cells and squamous cell carcinoma.
This is so interesting. Can you give us a little bit of a background, lay the groundwork for what is currently the typical standard of care? I mean, I know exactly the patients you're talking about. They come in with one skin cancer and you're looking at your face and you're thinking, oh my gosh, I think there's another 4 that I didn't see last time that are just, blossoming. What is the typical approach that many of these patients are given as an option, before you start talking about your therapeutic approach?
Sure. Now, these are typically patients above 65, I would say in the 70s, and they would come in, and typically what they're offered would be something called Mohs surgery as the first line treatment. And if that is If they come in, the skin cancer a little bit too large, and oftentimes radiation therapy, it's their second choice. Now, unfortunately, patients are not excited about either one because of their advanced age and repeated surgery, especially in their face and scalp for men. Patient becomes more and more hesitant about coming in for surgery, and therefore they often come in later and later, and therefore requiring a larger and larger skin excision and flap, and it kind of creates a vicious cycle for the patients.
And so, Anna, I wanted to ask you, because I know that this is an area that you're really, I'm not going to say budding expert. You are a great expert now of treating these patients and have reported a lot on various uses of other treatments. What is your approach when you see these patients from standard of care, but also other preventative approaches? I know there's some things I learned from you about how to address the overall risk before you even get to treating the cancer itself.
Mm-hmm. So there are a special subset of patients that Dr. Shen treats, that we all treat, that are not easy in terms of what the standard of care offers them. So, obviously we're talking to all of our patients about how to prevent skin cancers with the standard sunscreen, avoiding the sun at the peak hour, sun protective clothing, helio care, and then there's other patients that it's just not enough. So we have other mechanisms to prevent using field therapy, applying some of these topicals that Dr. Shen used to prevent new skin cancer. So treating a certain area to reduce the actinic damage and hopefully prevent new skin cancers. That's one of our projects right now, seeing how good this combination is at preventing them. There's photodynamic therapy, acitretin. There's a lot of different treatments that can help reduce the number, the frequency of new biopsies for these patients. But in terms of treatment, then we have, as Dr. Shen said, Mohs, radiation, injectables, 5-fluorouracil, methotrexate, bleomycin, photodynamic therapy. But a lot of these treatments are very expensive. And this combination is a great option for patients that have sort of reached their tolerance for how many surgical procedures that they're willing to have done, that have a tumor burden so high that it's not easy to excise all of the tumors.
Right. When I see these patients, I often think okay, the system has broken down, right? Our system of defense, be it the biological, some genetic pretext there as well, they just can't keep up. We can't keep up. So those are the patients we're talking about. So I want to go back to you, John. You seeing these patients come in, and then you want to start this cocktail. So let's dive into it and tell us, what is the cocktail? How is it used in the research you've done, but also in practice? How do you use it?
Sure. So usually what I do is I have patient come in for full body skin exam, or they are trained to look for early skin cancers. And so they come in and we do a biopsy. And actually at that moment, we will instruct them through a video on my website at shendermatology.com, where it teaches them how to apply 1/5 pea size of tretinoin and 1/5 of a packet of imiquimod and 1 drop of 5-fluorouracil, 2% 5-fluorouracil, a Band-Aid. And they actually apply it to the biopsy site immediately. And within 2 weeks, we let them know the result of the biopsy. Most of the time, it does come back positive, but they start their treatment right away. And at the time of biopsy, we also apply a little bit of cryotherapy for about a second, leaving about a 1 to 2 millimeter margin before initiating the first topical treatment. And we actually do the cryo on each visit as well. We find that to be helpful in allowing additional penetration of medication. So we see the patient back every 2 weeks during that course of time, and with a brief cryotherapy, and I take clinical images of their treatment site. And at home, patient actually watches the video about the side effects that are expected. And they're also given a topical clobetasol, 0.05%, and they're instructed that if the symptom becomes unbearable or uncomfortable, they could apply it twice a day for up to 3 days. Though I do find that most of my patients don't ever use clobetasol during this treatment.
So John, just to kind of capitulate what you're saying, so you have them on imiquimod and 5-fluorouracil.
Correct.
Is that right? And
Correct.
then what you do is you're starting it off with a little bit of cryotherapy, I'm guessing to swell the tissue. And then
Yes.
how do you incorporate the tretinoin into this? And then I understand you're seeing them every 2 weeks. So I had a follow-up question, but first I wanted to understand, how do you incorporate the tretinoin? Is that being applied at the same time too?
Yes. Actually, all three are being applied simultaneously.
I see. Okay, so you're really trying to enhance penetration. And then
Exactly.
with these
Exactly.
follow-up biopsies, how many follow-up biopsies do you typically end up doing on these patients as you're monitoring them?
It's interesting. At the very beginning, I would say 15 years ago, I performed a lot more follow-up biopsies just to be sure. But it didn't take very long for patients to realize that the biopsies were always negative and they actually did not want follow-up biopsy. So we switched to more of a clinical follow-up. And a lot of these patients would stay with me for 10 years, 12 years, for a very, very long term. And so the word of mouth kind of spread so that everybody started coming to see me precisely because we do the initial biopsy, we treat, and then we do clinical follow-up.
I see. Okay, so you're not doing too many biopsies anymore.
Exactly. In fact, that's the reason a patient want to see us is that they don't want to be cut. They're really sick and tired of being cut.
Yeah, exactly. And this sounds, though, quite irritating to the skin, right? The repeated cryo, all these medications that have pretty irritating side effects. So how do you really coach patients about this? And when do you tell them to stop? What's the clinical endpoint that you're looking at the skin?
Sure. So I think the crucial part is the dosage. I find that a fifth of a pack of imiquimod, it's the most you ever put on. I discovered early on that one pack of imiquimod is just too much strength. It's too much power for skin cancer treatment. And a little drop of 2% 5-fluorouracil is just about right to enhance the penetration without kicking up too much of an inflammatory side effect. And of course, a little bit of tretinoin, a fifth of a pea size. It's just the right dosage. Now, it's taken me probably a decade to kind of perfect that dosing, but I found that it works great with very minimal, actually, it's quite tolerable. So that very few people actually quit from the treatment. Almost never, actually. Yeah.
Yeah. And one of the things I think we talked about the kind of gestalt of the patients, but we haven't talked about the actual tumors this is effective for in your experience. Can you tell us which types of skin cancers and the subtypes?
Sure. We actually apply it to basically your major types of basal and squamous, so superficial basal cell, nodular, and morpheoform basal cell. And for squamous cell, we apply for squamous cell in situ as well as invasive squamous cell carcinoma. And keratoacanthoma kind of falls within that category as well.
Wow. So this is essentially our bread and butter, the stuff we see every day in clinic.
Bread and butter, yeah. It's not anything exotic.
So I want to turn to you, Anna, now, because you've come to this maybe a few years after John's been doing this and decided to dig through all the data, and that was recently published. Can you tell us how you went about the research and what have you found?
So we took an approach to look at all of the tumors that Dr. Shen had biopsied over a period of time. We identified about 500 patients, about 700 cases of basal cells and squamous cells, and then
Wow, that's a good number. Okay, that's a great number. Yeah.
that's what we started with. And then the study inclusion was we wanted to look for the patients that had completed the prescribed treatment. So patients are advised to apply the combination 5 times a week for 6 weeks, so a total of 30 treatments. Some patients that aren't able to tolerate the, local skin reactions, they're able to reduce the frequency. So they can go down to 3 times a week and they just extend it to 10 weeks. The goal is the 30 treatments. Most patients are able to tolerate it 5 days a week. In my experience, Dr. Shen has more patients, of course, that have done this, but in my experience, the patients are able to plug through. So we found the patients that had the biopsy-proven basal cell or squamous cell that completed the 30 treatments, and then patients that had a clinical examination 3 years after the treatment or a documented treatment failure, which was persistence or recurrence of the tumor within 3 years. And then that brought us to 186 tumors, so 97 basal cells, 89 squamous cell. And it's a labor of love project. But you have to, you click on the patient, the tumor, and we go through every single note. And it's really a lot of work. But the team that we had, I think they were spectacular. They did an amazing job. And, this was a project I think that Dr. Shen had wanted to do for some time. And it was just a matter of having the right motivated students and fellows to help us, extract this data and then compile it. So we looked at different combinations that Dr. Shen had used over the years. So the combination of imiquimod and tretinoin, 5-FU and tretinoin, and then the triple combination, which we refer to as the Shen cocktail, which is the, really the most effective combination and the one that he's using, routinely now.
Got it. But not to be confused with other cocktails. Don't order those in the bar, please. Okay, good. Go ahead.
Yes. So we looked at all of those combinations. So, throughout the iteration of this treatment and found that they were all very effective. The overall, clinical cure rate was very high for all of them, but the imiquimod 5-FU tretinoin combination was 99% effective when you looked at all of the tumors. So the tumors that were most challenging to treat were morphiiform BCCs, but we didn't have a huge number of those. But in terms of the takeaway message, I think that, and maybe, Dr. Shen, you can correct me, but at least in the data that we have thus far, that we've been able to assemble together, it seems like that's the tumor that's the most challenging to treat.
I agree. I think that's probably the only one where I would reserve for, say, patients in their 90s, and they really just don't want another Mohs. And I explained to the patient about the cure rate. It will be lower, it could be in the 60s, but oftentimes those are the patients that says, you know what, I'm just too old for surgery. Please just give me the Shen cocktail.
Yes, absolutely. And I just want to say that congratulations, because your labor of love has been published now, and it's available for people who want to read it. I believe it's the Journal of Drugs and Dermatology, early in 2021. So anyone who is looking to understand the cocktail specifically, do it. And please remember, if you're not a physician listening, you got to do it with your dermatologist. And I want to ask you a question about what have you found in terms of side effects? I know, Johnny told us that it's a little irritating, but with the right cocktail, you found that it's not so irritating. What have you found in your data chart review?
So, patients should expect redness, erythema, usually erosion. So the lesion often, or the site often does ulcerate. And you would think that, that would portend a poor cosmetic result, but it really is incredible how it heals. We published, there's a few examples in the paper, and I have really dramatic examples of large tumors that I treated. And, the site had ulcerated and you can barely see the scar. Imiquimod has some ability to remodel scars. It has some, I think that's probably the mechanism that it's from the imiquimod, maybe the tretinoin too, but it really is amazing how well they heal, because it can look a little bit intense.
Yes.
It can look a little bit intense.
Yeah, as we're speaking, actually, I'm looking at these pictures and it can look intense, but the post pictures are just incredible. It's unbelievable.
And this is typical. This is not like the cherry picked best cosmetic outcome.
I have to ask here, John. So, a lot of people are going to say, if it's morphiiform, I mean, obviously this is incredible kind of cure rates that you're reporting. Were the majority of these tumors, were they superficial, nodular? I mean, how many of them were morphiiform? Because, a lot of us sometimes struggle with that, having perineural invasion and things like that. Are there limitations where you'd say, hey, this cocktail may not be the right step?
I would generally focus on, I think the size is really crucial. The average, obviously the median's lesion size 6 millimeters. So it's not big. Gunning after anything that's even, I would say 2 centimeters, kind of the upper limit. I don't really go beyond that. So to catch it early is really crucial. It really makes a big difference. And morphiiform, I would say I generally steer away from it. We do have patients that request it. We're not going to deny patients who may have end-stage cancers and other cancers and end-stage diseases, almost more like a palliative care rather than anything else. But most of the time, I would say superficial and nodular, basal cell, and then the invasive. The squamous cell seems to respond quite well for some reason, it responds extremely well. So I hope I did not forget to answer your question.
No, John, I think what you're bringing up is, I think, a really important point that all listeners should also pay attention to, is that it's one thing to have an algorithm in place, or not even an algorithm, like a method in place, but it's another thing to deliver that. And there's an art to delivering it and choosing the right patient and picking the right kind of informed conversation. And then, some patients are going to say, I don't want Mohs. And then you tell them this is, the certain standard, and they'll say, that's not what I want. And so I just want the listeners to not think that this is just this is a very experienced practitioner, both Anna and John, utilizing thoughtfully care approach in selected patients with a lot of complex, reasoning that's in there. So I would highly encourage anyone that's interested to perhaps follow up with John. You're okay if they follow up with you?
Absolutely.
To learn more about this, because I think carrying out these kind of treatments really is in like patient selection too, I would imagine.
Absolutely. And I would say that early on, I would have a seminar in my waiting room where I give patients all the options. And maybe only a small percentage of people would prefer non-invasive immunotherapy. Now, over time, obviously, as we have successful results and word of mouth starts to spread, people started to drive farther and farther, and even flying in to see us from other states, specifically for immunotherapy and topical immunotherapy. And so you're absolutely right about patient selection. It's important for the patient buy-in, that they know what to expect, what they're getting into before they start.
Right. And just to reiterate, in our neck of the wood, this is not terribly rare patient. And we've seen a lot of the side effects of other treatments. I take care of a lot of patients with chronic wounds, and it's not uncommon to see patients who, have had it with surgery, so to speak, and then seek other therapies, one of them being, for example, radiation. And that has its own side effect. Forget cost for a minute, but just I've taken care of some terrible radiation ulcers that have been used now on more invasive cancers and such. But really, like Raja said, it's a thoughtful process, selecting the right patient,
Yes.
having the right conversation. So certainly there's an art based on a lot of science behind it. I wanted to ask you, what's the next step now? Are you going to study this prospectively? We do have a bit of a limitation, right? This is a retrospective analysis, be it with a relatively large number of tumors. Would you consider studying this prospectively?
There's a lot of questions, and we're hoping that we can move forward with a prospective study. It's, finding the right funding agency, always that is the issue, but we could probably recruit this study in a month in Miami. John was so gracious and let me come to his clinic, and he showed me the secret sauce. He showed me exactly how he does his seminars, how he coaches his patients about what to expect. And I learned so much, and I try to mimic as much of that as possible. And I talk to every patient about all of their options. And it really is about finding the right person, the right patient, the right tumor, the right time. And I have them come to clinic with all of those medications, just like, Dr. Shen does. And I show them the exact amounts to apply so they can't do too much, because I had one patient when I first started doing this, and he really went rogue. It was a disaster. He thought, well, if a fifth of a packet is good, then a whole packet is great. He really was motivated to avoid Mohs for squamous cell carcinoma in situ of his scalp. So, that was a very good lesson for me. I never let them just apply it. I have them come and I show them exact the amounts. I have them take a picture with their phone, and then I apply it for them the first time. So, it's really important. They can do some harm if they go rogue.
Absolutely.
So actually, Anna, one thing that you may not have seen was that since the COVID pandemic, due to social distancing, we have created videos on our website, shendermatology.com, where we teach people how to use Shen cocktail for skin cancer, and a separate video called Shutting Down Inflammation. And that has vastly saved me a lot of time, because we anticipate basically the 200 questions that they're going to have, and we address them in a very efficient way in the video. And I think that's really the way to go in the future of medicine, is to kind of like what you guys are doing, just educating in a way that broadcasts the knowledge. So that will save the visual encounter that we have with patients.
Hey Raja, do you know where the integrative medicine movement started?
According to Google, since Google knows everything, Dr. Andrew Weil founded the Center for Integrative Medicine at the University of Arizona in Tucson back in 1994. Why do you ask?
Well, you know how we always try to get to the root cause? I think we need to go big for the fifth annual Integrative Dermatology Symposium. How about we do this? Let's meet at the Los Ventana Canyon Resort in Tucson, Arizona. Or you can join virtually from September 30th to October 2nd and hear from the world-renowned experts like Andrew Weil.
Exciting. And our theme is connecting mind, body, and spirit to take a more holistic approach to our patient care. What do you say?
Absolutely. I mean, where else can you get the latest on diet and dermatology, hypnosis, botanicals, common diseases, aesthetics, and other unique topics in dermatology with practical takeaways to start using in clinic right away?
So true. And let's not forget, we've got the new track for estheticians too. I think I'm going to need to call in a sick day or two before the symposium so I can enjoy the waterfall and trails on the resort, stargaze, play a round or two of golf or tennis, relax at the spa, and catch up with colleagues at the evening receptions.
Yes, that place is spectacular. You know, use our discount code POD25 at checkout for 25% off.